Good morning, everyone. It's still morning. It's 11. Welcome to our Navigator Training Focus Series. We are talking today about engaging special populations, which are veterans. This is our first training devoted solely to our veteran population, and we thank them for their service. And we are really excited to bring this training to you today. We have some great speakers. We're going to just wait a few more seconds and we're going to get started. So I'm Sherrie Cisneros. I'm the Navigator Program Director, and we are more than welcoming you to, if this is your first training, welcome. For those that are with us for all of our trainings, we welcome you back. All right. As you know, CA Bridge is a part of Bridge, our overall organization, and we are a program of Public Health Institute, and we are directly correlated with Department of Healthcare Services, and we are happy to have you here. Next slide. So CA Bridge, you know our goal is 24/7 access to substance use navigation and addiction treatment in every CA hospital. We came very close to our goal, and we're still striving to expand treatment throughout California. And you are a huge part of our movement. So we, again, thank you and appreciate you for all of the hard work that you are focusing on people who use drugs and who are in need of treatment for MAT. Next slide. So is CA Bridge? We always like to just start with our model three-prong approach, low barrier treatment. That's what our healthcare providers are doing in the clinics, in the hospitals, in primary care. And then the last two pillars are connection to care and community and culture of harm reduction. This is what our navigators, our substance use navigators are doing. And you may be called different things. We may be called a CHW, peer support specialist, some of your social workers. We welcome all. It's one title. We are all here to help people with substance use. So that's our CA Bridge model. Next slide. These are our objectives today. If you are a CEU learner and you need CEUs for CHW renewal, for your CADAP, CCAP, or peer support specialist, we do offer renewal provider CEUs for today's 1 hour session. So we have some announcements. We're always wanting to promote our next events. And so coming up in July, wow, July's already here. I'm going to share, I had a mentor tell me when July gets here, it's already Christmas. So let me put that on your mind right now. So it's July. We have our Navigator update, and that is on July 9th. And it's going to be an update about CFR Part 2. If you need some guidance, some questions and coaching, LaToya will be leading that update. Our next Navigator Focus series next month is engaging special populations with LGBTQ, and that will be on July 24th. Next slide. We also have our Navigator peer support was just yesterday. So next month is July 30th, and that will be here before we know it, you guys. Wow, we're already in July. And then you know what's in August. If you know what's in August, that's our big, huge time and opportunity for you to promote. What is it that happens in August? Anybody know? Overdose prevention. Yes, Rebecca Harris, ding, ding, ding. I'm so excited about this. So if you're not planning something, this is a great day for you to promote your MAT program, to bring out awareness, to give out naloxone, and look for more information about a certain challenge coming up. Next slide. We also want to promote our CA Bridge regional collaboratives. We've had some all over the state of California. Our next collaborative will be in the Inland Empire for the San Bernardino and Riverside counties, and that's coming July 25th. So we got lots and lots of stuff coming up. In September will be our virtual for all regions. So please join us. We would love to see you there. Next slide. So we have one of our favorites here today, Arianna Campbell. She is a physician assistant at Marshall Medical. She's been doing this for a very long time, and I'm so proud to say she's one of our founding members of Bridge, making this wonderful organization, and her passion for helping people is just amazing. And we are excited to have you here, Arianna. And I want you to explain what you do for VA, because we don't know you in that role. We know you
Sure.
as, running your clinic and helping people. So explain what you do for the VA. We're so excited to have you here.
Thank you so much, Sherrie. It's always my favorite thing. This is my favorite group of people, the Navigators in California, who are just heroes, and honestly, the realization of a dream that me and a few others had when we formed Bridge, many years ago. So yeah, I have been working at the VA actually for a while in the emergency department, but in what we call the Arts Clinic, which is our addiction psychiatry clinic. I've been working there now for just a little over a year. And so my role actually is I do see patients. So I still work shifts in the emergency department, and I also work in the addiction psychiatry department where I see patients for a range of substance use disorders, and we give a range of treatments which I'm going to talk about. And I can tell you I worked in a rural hospital and still do some work out of Marshall Hospital in Placerville. So I think I come from a perspective that's pretty similar to a lot of people here, where I've been working out in the community, but now I'm working at the VA, and my role actually they made a position that's called buprenorphine access. So I'm for the Northern California healthcare system. I'm really trying to envision what it's like to increase access to buprenorphine for our veteran population. So next slide. I'm going to talk a little bit. We do have a high prevalence of substance use disorders amongst our veterans. So in 2020, SAMHSA did a study and found that 5.2 million veterans had a mental illness and/or substance use disorder. And in our addiction psychiatry department, we definitely see the mix. We know that people have many things going on, and so we have really brilliant people who consider as a whole person approach our veterans, and we work with people to get them connected to treatment and to provide the kind of treatment that is individualized. But we know that when you we look, there's a lot of intersectionality here. So we know with veterans with a substance use disorder, 4 in 10 struggle with illicit drugs. 7 in 10 with alcohol. We have a pretty high prevalence of alcohol use disorder, and if you dig into this, high prevalence of binge alcohol drinking too. And then we do have 1 in 8 who struggle with both illicit drugs and alcohol. And then when we look at mental illness, 1 in 3 had a serious mental illness, and so we had 3.9 million people 18 or older with a mental illness, and then you can see that 1.1 million 18 or older had both an SUD and mental illness. So it's really important. We have many programs to address this and to give people access to care. Next slide. I also want to note that actually one of the things that I've looked at is, Veterans Affairs is actually a leader in addiction research, and I didn't realize some of the innovative work going on there until I started working there. This was a study that where we were looking at tapers of opioids. Anybody who knows me knows that an issue of mine has been these rapid tapers of opioids and some of the issues it causes. And the VA actually, Agnoli here is, and others led some research in looking at this. And what we see here is, if you look at the horizontal axis, we see the reduction velocity. How quickly are people decreasing? When we looked at deprescribing opioids, and this has been something where we saw this massive decrease in opioid prescribing, which we all thought this is a good thing, right? We should decrease opioid prescribing because people are dying from overdoses. But really, what the VA found is when this was done too rapidly, not in a patient-centered way, that you can see on the left that we see increased overdoses. This increase in overdoses with these rapid tapers, and really an increased overdose with any taper at all, especially when this is not patient-centered. And then on the right, you can see an increase in mental health crises. So just something to be aware of that. And the VA has really been looking at this, and we have teams who look at overdose risk, and we really try to take this patient-centered, individualized approach direct, when we are prescribing opioids, we have a lot of systems, checks and balances there. And we also look at tapering folks and look at different, we prescribe a lot of buprenorphine now actually for chronic pain because of its safety. Next slide. And we're really looking at access. So I show this slide because this is a lesson from Bridge, right? We learned that putting posters in the lobby is a big deal. I hope a lot of you navigators have done this. Put some posters in the lobby of your emergency department. Got a captive audience there. But I want you to look at the words here. VA is here to support you no matter your goals. So actually Carla Figura, who's one of our clinical pharmacists, she leads harm reduction efforts at the Northern California healthcare system. And really the message here is that, there's probably a lot of misinformation about, we'll meet you where you're at. So we give personalized treatment. We have a lot of harm reduction groups. We have peer support groups, and we do a lot of medication treatment. We have wonderful social workers who do a lot of really, evidence-based treatment. And we focus on the evidence. Like I said, VA is a leader in addiction research, and we really try to follow that evidence in what we do. And we know that it's really important to get access out there and to make sure people know that we can help them no matter where they are. We're very focused on overdose prevention. Next slide. So this is actually a pamphlet that we have. I note that we have a phone number on there. So, and if this is for just our Northern California healthcare system. So, and I think Heather's going to go over what some of the different regions look like, because I know there's people here from all over the state, but your own local program may have a phone number, but we have a harm reduction team. And so people can reach out and connect with our harm reduction team. And we also have, ways of getting people into treatment, of course, and our emergency department, of course, does a lot of work in access to care for addiction treatment. And then we have our arts department who is really focused on that individualized patient-centered care. Next slide. And we actually do, from our emergency department, a lot of things that I know a lot of you navigators have worked really hard on, like getting naloxone access, fentanyl test strips, harm reduction resources, buprenorphine on formulary. We do that at the VA. So, just in my Omnicell, in the emergency department, we have easy access to naloxone, so we're able to distribute naloxone. And we also have fentanyl test strips there. So we're trying to get this stuff out there to create safety, and so that people, we're again really focused on efforts to decrease overdose deaths. We have whole systems in place to review overdoses, and we care about our veterans. We're working really hard to, like I said, provide resources, knowing that every overdose is preventable. Next slide. So I'm going to talk a little bit about some of just, a few of the specific services that we offer. So for alcohol use disorder, we definitely have, we have providers, clinicians who provide medications for alcohol use disorder, but we also have an alcohol harm reduction group. So we look at people who may not be ready to stop drinking. We give medications also to people who may not have stopped drinking. It's not a requirement. And we provide support for those who may still be drinking. We have multiple groups to just meet the needs of different people. And then we also have an arts bridge, or the bridge clinic, where sometimes when people have difficulty accessing like their first appointment with one of our social workers, we actually have a clinical pharmacist and our medical director who give quick access to medications. And coming soon, we're going to have an ambulatory withdrawal clinic. So we try to think of all aspects of care that our veterans need and provide that for them. Next slide. For opioid use disorder, this is how I got into addiction treatment and how I started, I innovated a program at my rural hospital. But, we, in our veterans, we see people who are using fentanyl, people who are using, prescription opioids or oxy from the street, a lot of kratom. We see a lot of kratom in our veterans, and of course, some heroin too. And we treat very aggressively with buprenorphine, all forms. So we have all the injectables at our ether facility. We have also a lot of different satellite clinics out there, different clinics in different areas who do give injectable forms of buprenorphine. We also help arrange for methadone treatment. I've done methadone initiations in the emergency department, and we help continue people in methadone treatment in the community as well. You check with your local VA to see how they do do this. And we also have, like I said, naloxone distribution programs, pretty robust harm reduction where we even send naloxone out to our veterans. So again, we try to think of how to keep people alive and how to offer treatment and access to care from every angle. Next slide. And then for stimulant use disorder, we actually have contingency management. We have a really cool contingency management program. If you talk to our clinical nurses in our clinic, they'll say that this is the favorite thing that they do. Bill and Nancy love to run this contingency management part of this, and our Dr. Batian runs that. But we do a lot of harm reduction, and we do a lot of co-occurring, services available for co-occurring disorders. We also have resources for housing. So we really, again, try to see our veterans as a whole person. Next slide. And then I just want to point out, and I think Heather's going to focus on this a little bit as well, but VAs, all the different VAs, it's kind of confusing. I'm still on the spectrum of learning, but we have different healthcare systems across California, across the US, actually, different regions. And many EDs have hotlines available for assistance with complex withdrawal cases. We actually have an emergency department hotline that contracts with our VA, and it's some really brilliant emergency department, dual boarded emergency medicine and addiction medicine physicians who will help with complex withdrawal cases. We also have, again, within our facilities, we have addiction medicine resources, but this varies from region to region. They're not even all called arts clinics. They're just, they have different cute names, but so just know what's available in your area. We also connect people through, there's this Veterans Justice Outreach. So we have a program where we have a group of people who look for some of our veterans who may be justice involved, and things pop up and they'll try to connect veterans to care. And so I will see a lot of people who maybe got connected through what we call VJO. We have housing resources, we have work resources, we have pain, substance use disorder clinics. We really look, we're super obsessed with looking at overdoses throughout our regions that we're working in and seeing how we can prevent them. So just wanted to give that broad overview and allow time for the other speakers here. So that's it. I'm happy to also take any questions.
Thank you, Arianna. It's always so wonderful to hear you speak and hear all of the fantastic things that you're always doing. In the interest of time, I am going to ask that the audience type any questions that you have for Arianna in the chat. She is a wealth of knowledge and information. And I'm going to introduce our next speaker, which is Dr. Mercedes Patee. Or Patee.
You had it right,
is
Patee.
okay, Patee, who is a board certified physician and former U.S. Naval flight surgeon, impressive, who served active duty providing medical care and aviation personnel and operational units. Following her military service, she founded Renewed Life Medical Group in Redding, California, where she currently leads innovative efforts to expand access to addiction treatment and integrated care for underserved and justice-involved populations.
Thank you so much. I appreciate it. So yes, I am a veteran and I have a heart for veterans, and it's my pleasure to talk with the substance use navigators. So I'm ER certified, and I worked with our substance use navigator here in Redding, and I love them. There's currently 3 here in Redding that I think that we're working with, and they're so good. The hospital needs more of them to cover all the hours, and I feel so privileged to be able to present this for our navigators. So I'm gonna spend just a little bit of time here on a couple of these slides. I just putting things in perspective. Arianna did a great job with the information as to the prevalence with substance use disorder and mental health. I'm going to break it down just a little bit in the context of someone who's got a history of military service, and why it is that why is this prevalent? So it's about 1 in 10, maybe a little bit more, veterans struggle with substance use, which actually is not very different if you adjust for age in the general population. It's actually very similar. So why is this a big deal? Well, because the overdose risk and the complications that come with veterans. So it's twice the overdose risk. In the general population, if you get 100,000 people, 33 will overdose. It's 60 to 70 with veterans. Why is that? Well, for several factors, and you may have heard and have somewhat of an understanding of these, but I'll just kind of explain why these are more common. So PTSD is 2 to 4 times more common with veterans, and then depression 2 to 3 times veterans more likely to have depression. Now, a lot of these numbers are actually probably lower than the real number because veterans really don't have much of a trust in the system for multiple reasons, which we will talk about. Also, pain is much more common, obviously, because of trauma, injuries, and all of these greatly increase the risk for substance use disorder. Many of these veterans will not ever enroll in the VA, unfortunately. You know, as many services as the VA has, they will not enroll. Either there's a mistrust to the system, or just maybe the substance use or the mental health will just kind of get in the way for them to actually go through the process of enrolling. Perfect. Okay, so PTSD and trauma. I'm going to talk a little bit more about military sexual trauma, but PTSD and trauma. And just a refresher, PTSD is when someone experiences some sort of, or witnesses some sort of life-threatening or traumatic event. It doesn't have to be a one-time thing. It can be a chronic thing. And what happens in the brain is no longer able to process danger and safety, that balance, danger and safety well. So the person remains in this state of heightened alert and fear, even when the danger is not present. So the symptoms that someone would get is like kind of re-experiencing. So that could be flashbacks, it could be nightmares. A big one is avoidance, and that's a big reason that a lot of veterans don't access care or don't go to the VA because they're trying to avoid everything that reminds them of their trauma. Also hyperarousal, which is irritability, trouble sleeping, being on edge. So maybe they're not the best patient when they're waiting around and there's a lot of people around. It can be a little tricky. And then there's a lot of negative thoughts and mood. There's a lot of guilt, shame, sometimes numbness or trying to detach. Some of that has to do with moral injury. Moral injury is it has to do with the identity, right? So you do something in the service because of the situation you were in, either because of it was ordered to be done, or other people were doing it, or it seemed like the right decision for life-saving thing at that moment. And then they live with that guilt, right? So some of them talk about, they're facing people overseas that are, children that are armed, right? And they're fighting against children, right? So there's that moral injury of having attacked, killed potentially someone who's a child. So a lot of these things hang very heavily. And then another major risk factor is civilian reintegration. Why is that? Well, because in the service, there is this very strong sense of belonging. There is routine, there is structure, and there is purpose, right? So when a veteran leaves the military, or when a service member leaves the military and then goes into the civilian sector, it can be very difficult. And I had a great experience in the military, and it was difficult for me. It is difficult because now there isn't that well-defined structure. And then now you're finding that you're doing things that don't seem to be so purpose-filled, right? You're not fighting for your country. You're not saving someone's life. You know what I mean? And so you feel like maybe people don't understand you, or people are superficial, or it's just everything had so much meaning to it. So reintegrating is a big thing. Also, the civilian in the civilian sector, a lot of the stress that someone may have gone through in the military is just not well understood. So these are all things that cause veterans to experience isolation, pain, loneliness. And so how do you deal with these? Substances, right? So let's go to the next slide. We're going to talk a little bit about the military structure. So in the military, and this is in context of military sexual trauma. Why is that an issue? Isn't there sexual trauma in general? Yes, there is. Why is the military a thing, the military sexual trauma? Well, it's because of the culture. There is a chain of command and a rank structure. I remember when I went into the to do my internship at the hospital, when you go to most hospitals that are civilian hospitals, the chain of command or the people that are in charge is if you're a doctor, you give orders for the patients, the nurse carry them out. Everyone kind of just has to follow along with whatever the doctor is doing, right? So that's because of the way the system is set up for patient care. In the military, it's incredibly structured. It's all about rank, right? So I had nurses that I answer to the nurses because they ranked over me, right? So there's a very defined structure, and it doesn't matter what you're doing. The rank is the rank, right? So the chain of command is so important. Why is that a big deal? Because there is this sense of authority that people have. And so when it comes to having people under you, when you have that authority and that power can be misused, and it often is misused. And so when someone is undergoing either a sexual assault or even sexual harassment, sometimes there is that sense of inability to do anything about it because of that rank structure and that power. And then the culture tells you, tough it out, don't show vulnerability. And then there's a lot of shame and guilt, especially among those who are trained to defend, to not have been able to defend themselves. And now if you ask for help, you're admitting that you were too weak, right? So that in itself will prevent people from getting help. And then also there is that sense of you don't want to destroy your unit's reputation, right? And if you speak up, it will cause damage to the unit's reputation, which you let everybody down with, right? So there's a lot of intimidation, a lot of coercion, and then there's the fear of retaliation, right? You can lose your career if someone doesn't believe your report, then people in higher rank can affect where you're sent, if you're promoted or not promoted. So there's that fear that is very real. And then also there's this structure where you're working with people in very closed quarters and you're isolated. And so you can either be deployed or high stress environments at work. You can be remote or limited access to someone that can actually help you. And in the past, historically, there has been and I wouldn't say just historically, but in the past, it was very common that there was a lack of accountability for offenders. And so no one was getting punished. And so there's a lot of repeat offense. So how do you put this all together? Well, first of all, these are all risk factors that make it difficult to treat, to be able to approach a veteran. And so being aware of that, which, trauma-informed care, and then also understanding specifically the culture that a veteran was brought up in the military, is there is a way to approach and the way to have a veteran feel very safe. And obviously speaking respectfully, but very directly, and asking very specific questions. Trauma-informed language is just basically putting the power back on the veteran and saying, you are safe. No one is forcing you, letting them know this is what I'm going to do before you do it, and giving them an option to opt out or to even request, other things so they can feel more safe. Under this list, I have match gender for military sexual trauma. So, so especially when you're, and by the way, 1 in 3 women have experienced either sexual assault or sexual harassment. And I believe it was for men, 1 in 50 men. And it's probably more because you can't really talk about it. Okay, so it's quite common, quite prevalent. And so being able to, whoever is serving them, to be open to potentially bringing another provider, or putting them in an environment with either a nurse, whoever, that's a little safer, is super important for them to be able to open up and receive help. Okay, next slide. All right, so what do you want to ask? What branch did you serve in? Are you connected to the VA? Have you had deployments or trauma, so that you can be aware on how to approach and where to get services? Do you have housing, and do you feel safe? These are questions that sometimes are not as obvious. If somebody comes in and they seem to be well put together, or it doesn't seem to be an issue, these are questions that you need to ask to be more aware. A lot of times it's not very obvious. Okay, next slide. Here we talked about trauma-informed care, and veterans need to feel safe. And even if it's a safe environment, that doesn't mean they feel safe. And so being able to understand how they feel and what would make them feel safe at that moment. Trustworthiness, that's why speaking very directly is important. So there's nothing hidden, there's not a fear of, if I share this person what I'm feeling, they're going to now either diagnose me with this, or lock me up, or get me in trouble, or whatever it is. You have to be very forthcoming. They need to feel empowered. I think that's the big thing, where they get a chance to actually decide for their own health what's going to happen. Let's go ahead and go to the next one. All right, so these are the specific populations for veterans. So those who have experienced military sexual trauma, military sexual trauma is actually a higher risk for PTSD than even than trauma at war. Like actually having seen trauma at war, or having had exposure or a life-threatening event at war. Justice involved veterans. There is a whole system that works with veterans who are justice involved, taking into account what they've gone through, and that is more tailored to help them navigate the legal system to avoid incarceration, arrest, or recidivism, and that also have issues of substance use disorder, and these are available to you. And there we go. The veterans eligible for treatment court or for MAT services. Okay, next slide. So these are the options for treatment. There are some that have gone through the VA, and then you don't have to go directly through the VA, but they are available. And obviously MAT services, that you're aware, there's the behavioral therapy, and this can be for anyone. It doesn't mean even if they were not dishonorable, even if they were dishonorable discharge, so it doesn't have to be honorable discharge, even if it was 1 day in the service, it doesn't have to be a prolonged period of time. Let's get to the next slide. All right, so what's the best way to do this? The warm handoff is honestly the best way. And I tried this system to see if it works. I actually went onto the VA website and put in a little inquiry to see if I had a veteran in front of me that was not enrolled in the VA system, was not getting services. I contacted a veteran service officer, and I actually got a response right away. I got a call. Is the veteran still with you? How can we serve them? I mean, it was phenomenal. And so you're not alone. And so you don't have to figure all this out. And that's kind of the big thing I want to let all our navigators know, is you don't have to know all the services and get them enrolled in all of the services. You need to know who to contact. And the VA system has already a very efficient system to be able to connect with you, enroll the member if they're not already enrolled, and then refer them to all the services that are available. So, and there are vet centers. Again, there is no enrollment necessary. They don't have to be enrolled to the VA, but there are vet centers in all through California and other places that the members can go to and start receiving services and even have community on there.
Thank you very much, Mercedes. Such really valuable information that you shared in, and I appreciate being able to hear all of that. We're gonna go ahead and introduce our next speaker, who is Heather Marshall. So Heather is a licensed clinical social worker with an astounding and impressive 14 years of experience working at the VA. She has worked in a variety of VA programs addressing substance use disorder, mental health, and homelessness. Sorry, let me get to the right slide. And Heather is passionate about recovery, forgiveness, and restorative justice. So there we go. All right, go ahead, Heather.
Hey, everybody. Thank you for having me, and thank you for the amazing work you do. So I'm here to do more of a nuts and bolts kind of presentation. I'd like to kind of just share with you just some information about how the VA works and some information about how our substance use referral processes work and policies that we are held to. So some of you may know this, but just in case you don't, the VA is separated into a number of different medical center systems or regions that cover different areas. So in California, it's quite extensive. So we have the San Francisco VA. And by the way, if you have this PowerPoint and you click on sort of the header, it'll take you to the website for that region. But we have the San Francisco VA that covers kind of the west coast of California from San Francisco all the way to the state line. We have the Northern California VA system that's sort of anchored in Sacramento or Mather. Huge area that we cover most of the eastern side of the state from Modesto all the way up to the state line. Palo Alto VA, which covers kind of like the Bay Area south of San Francisco. The Fresno VA, which covers most of the Central Valley. And then the next slide, please. The Greater Los Angeles VA, which covers west, north, and east LA, Ventura, Santa Barbara, San Luis Obispo, and inexplicably Kern County. But I didn't set these regions. And then Long Beach VA, which covers South LA and Orange County. Loma Linda VA, which covers Riverside and San Bernardino County. San Diego covers San Diego and Imperial County. And then Reno kind of has its claws into sort of the super eastern part of Northern California. So on the east side of the Sierras, people who wouldn't be coming over the mountain, they might go to Reno. So those are the different systems that exist within California. About policies for treatment of substance use disorder. Okay, so maybe you know, maybe you don't know that the VA actually runs its own very extensive system of treatment programs. So we have a lot of residential treatment programs, also known as like domiciliary programs or RRTPs for residential rehab treatment programs. There are 260 total programs nationwide in 113 different facilities. So we cover, we'll have treatment tracks in those programs that are SUD specific. Sometimes they're PTSD specific. We have a lot of like housing tracks that are a little bit longer. We'll have treatment included, but also we'll connect people with housing resources with the goal of discharge to permanent housing. And then there's like some more specialty ones that are a little less common. So it'll be like specific like MST treatment programs or SMI treatment programs. Those are a little bit harder to find, but they do exist within this system, the domiciliary system. So the programs within California that run, or the medical centers that have their own VA treatment program are Los Angeles. They have a huge one. It's a 290 bed facility on the West LA campus. There's San Diego has their own. Palo Alto and Menlo Park has a program, and San Francisco has a very small one. And coming soon, but in VA time, that's like within a few years, hopefully. Long Beach is working on opening their own program. Loma Linda is also opening their own residential program, and Northern California is in the very baby steps of starting our own residential treatment program. So we're super excited about that. Important for you to know, as people who are linking veterans who are in your hospitals to treatment, that the VA mandate is to use VA programs as a priority. So initially, our mandate is to treat at what's called the least restrictive level of care that is appropriate for the veteran's needs. So we would need to assess each veteran and kind of determine what level of care they could most benefit from, starting from outpatient. If that doesn't work, then IOP, then potentially PHP. And if none of those would be sufficient, then we would be looking at residential treatment. If we are working on a residential treatment referral or feeling like somebody qualifies or needs that level of care, our mandate is to refer to VA programs as a priority. Okay, next slide, please. Yeah, so we would only look at like community care if the VA programs are not able to get somebody in a timely manner. The main eligibility criteria for going outside of the VA system is timeline of admission. So that is just something really important to be aware of as you are working with veterans, wanting to connect them to care. We have certain limitations in terms of what we can approve, what we can work with veterans on. So it is often the case that I'll receive information from a community care program that a veteran has been referred to them. And then we would pick up at that point and try to assess like what level of care they need, and work with them to try to refer to a VA program if we can get them into one. Sometimes that linkage has already been made though with, so the veteran has already talked to the community program and been promised all sorts of amazing things, or feels trust with this program that they've already talked to. So it can start us off on the wrong foot with veterans that we might be having our first contact with, that our initial interaction with them is to say, I can't do the thing that you want me to do. So it's hard to overcome that, and especially as you know, we've mentioned earlier in this presentation, the distrust of the VA or the annoyance with the VA system or bureaucracy or how it never works, that can sort of reinforce that feeling of the VA doesn't care about me when we start off on that foot with veterans. So super awesome important to know is, so there's a saying that says, if you've been to one VA, you've been to one VA. And that is very true. So I've worked for like 4 different systems. They are wildly different. So the way they function, their policies, how they refer, the resources they have in that area, how they use the resources, is all very dependent on the local system. So I could tell you, I could talk at length about what Northern California does and what our policies are, but I also know absolutely for sure that our policies are very different from like Fresno. It has like a totally different resource list that they're working from. So it's really important that as a sub-navigator in a system that you are aware of who the right contact is for the VA that works in your area, so that you can connect with them and help sort of make that linkage for the veteran to the VA treatment, so that person can assess and then refer to what the VA is able to provide. So sometimes in some systems we'll rely more on community care. Other systems, like for instance, like Los Angeles has that 290 bed facility, much harder to get community care when they have that huge resource and they can sort of provide that care on their own. So it's just really important to find the contact within that local system and make sure that you're working with them directly to make referrals that make sense for that system. I think that's about it. I just wanted to make sure that you all know sort of kind of the basics of kind of what standards we're held to, what our resources are, and to find a contact with your local VA. For myself, I prefer if people contact me by email. So anytime you want to find out if a veteran in your system is already connected to care with the VA, or you're trying to get them referred to VA treatment, please email me. I'm putting my email in this chat here. I'm in meetings way too often, and it's really hard for me to answer the phone. So for the most part, the best way to contact me is email, and I can help coordinate for NorCal. But if you're outside of NorCal, please just make connections with who your local VA person is. That's it. Thank you.
All right. Thank you so much, Heather. We have maybe just a couple of minutes to take some questions from the audience. I'm going to take a moment to look in the chat. So we have a few minutes to take questions for Heather, Arianna, or Mercedes. I see one question, not sure exactly who it's directed to, but if a veteran is Native American, are they able to be referred to a Native organization for recovery? It's a very great question. Thank you.
I would say in relation to sort of my presentation, it would still go through that same rules of what we're able to refer for. So if there is a local organization through community care that does sort of, that's kind of Native focused, it's possible if they qualify for community care that they can make that referral, but each VA is going to be different, and we can always sort of do kind of a case by case, like sort of bring in all of the factors in somebody's situation and then make the best treatment determination. But that wouldn't be like the only thing that we could use to sort of move outside of the VA system. So it's possible, but not necessarily guaranteed.
And so I think what you said earlier or just a minute ago was, really, really valuable in that, if there are questions about, or if you need to help coordinate or navigate care for a veteran, always contact your local VAMC to see how you can get them connected to that care. And so with that, I will also say there's a question in the chat asking about website directory. Heather did also mention that the slides, which we will share out to you in a post-event email, you should get them in PDF form, which does make the link clickable to access those sites that are near you. And we will share a resource that Heather shared with us as well. So you all will have access to that. Let's see. I'm not seeing any new questions. So I'll move on to the rest of our slides to kind of help close things out. And I really do appreciate our speakers today, because this is, we probably could do like maybe another full webinar of this content, because it is so rich and useful for the navigators. But I thank you, Arianna, Mercedes, and Heather for being here to talk with our navigators.
Can I ask a quick question,
Oh,
LaToya?
yes, sorry, go ahead.
That's all right. So really quick, I kind of have it a two-part. I think you answered the first one is, I get a lot of VAs that come in and one don't know whether they're with a VA or not. So that kind of makes it seem like they're not. So Heather, the first thing would be get them in touch with you so they can get involved with the VA. And then the second part of the question is, I have people that come in here and that are dishonorable. Do they still have, sounds like they still have benefits, it's just maybe limited?
I will say, so if they're within the Northern California system and you send me their information in an encrypted email, I can check to see if they're already in the system, and I can then start the process to get them connected to treatment. If they're not in the system, and NorCal, I can only see NorCal, so I can't see Palo Alto, I can't see Loma Linda, so I can't check for the whole state. I can only check for NorCal. So that's why it's important to find a local person that you can have this connection with.
This is back up at Folsom.
Okay, yeah, so I can help for somebody in Folsom. So if you give me their information, I can check if they are in the system and are enrolled and eligible for healthcare. Then I can start the process to get them connected with us for treatment. If they're not in the system, then it has to go through enrollment first. They will determine whether or not they're eligible for healthcare. That would be the first step. So there are like some exceptions and caveats. If somebody has a service-connected condition, they can get care for that, even if they're otherwise not healthcare eligible, but it can be pretty layered. So it's really important that they are connected with the enrollment people to get that clarified. And I can't really help with that. That has to go through the enrollment department.
What about dishonorable?
If they have a service-connected condition, then they can get treatment for that condition. If it's dishonorable or OTH, then generally there's a process that they would need to go through to to try to get their discharge upgraded. Otherwise, we have some housing programs that are available for vets that are not otherwise healthcare eligible, but most treatment is limited.
Good, thank you. Hope you feel
Can I-
better.
Can I share for the vet centers? Those are available, whether dishonorable, not dishonorable, or VA or not VA. And then I didn't show this slide just because of time, but one of the resources that I put in there are the substance use navigators for the VA in California. There's a contact info. It sends you to a link. And then depending on the region you're at, you can click on that and see who's your substance use navigator contact.
Thank you, Mercedes.
And again, reminder, you will have access to all of these slides after this webinar. I do see that there is one more hand. If we can be very brief, go ahead, Roger.
I'll be very brief. Heather, good to see you. Thank you for the work that you've done with me in the past. We work with our county Veterans Hospital out here, and we've had nothing but great success with you. I think you're awesome, and I'm sure you remember me. I stepped on your toes a couple of times. I'm sorry.
All right.
That's all.
Thank you, Roger. Thank you very much. That was very, very nice of you. So you'll all have access to this knowledge check. Go through it and test your knowledge on what you learned during this really, really great webinar. As a reminder, these are our resources. You can scan this QR code to take you directly to our resource library. Which is some really great curated stuff for you and for probably others that you work with. We also have our CA Bridge Academy, which provides training modules for your prescribing clinicians, your social workers, nurses, and definitely for all of you, those of you who fall under the category of CHW, Navigator, peer support specialist, health educator, so on and so forth. You can contact us at mentors@seabridge.org. We are fairly responsive and really great timing. So I implore you to use this email to send us any questions that you might have, questions that maybe come up later about this webinar or about other things, even for CHW certification, or our upcoming other upcoming webinars or regional collaboratives. Chaya and myself make up your Navigator team mentors, in addition to a range of volunteer mentors. And our fearless leader, director, Sherrie Cisneros. This is her contact information. I thank you all so much for just, spending the time with us today. It's so important that we make information available to you that is relevant to the work that you're doing. So in the post-event email, you will receive a survey, and we very much value your feedback on how useful this information was and what other future topics you would like for us to cover, and things that we can include that make the learning experience more enjoyable for you. I thank our speakers. We could not have pulled off this fantastic webinar without you. Thank you very much, and have a great rest of your day, everybody.
Bye, everyone.